Good afternoon, everybody. So welcome again to Rounds. Today we have THETA Rounds, and I have the pleasure, probably the first time in my career, of introducing Dr. Murray Krahn, who you all know as the director of THETA. He's also a scientist at TGHRI and a professor of medicine at the University of Toronto. Just waiting for a few more people to take their seats. I'm also introducing Dr. Gebremedhin Gebretekle, who's an assistant professor at the University of Addis Ababa, or Addis Ababa University, it says here. He's a doctorate in public health from Addis Ababa University, and is here as a postdoctoral fellow in health services research at the University of Toronto. And they're here today to talk about something that I have an interest in, which is research opportunities in Africa. In this particular instance, it's HTA, and they're going to talk about a number of things related to the EuroQol, recent meeting in Africa, and ongoing health HTA projects in Africa. So I'm not sure which of you is speaking first, but I'm looking forward to this. Thank you.
Thank you, George. So as you may or may not know, we had a cancellation. We're not the people who are supposed to be presenting today, so Gebremedhin and I are a last-minute replacement. So bear that in mind when you look at our talk very, very critically. So we thought, what can we do to talk about what's happening in Africa? And I'm going to talk just briefly about how our collaboration with Addis Ababa University developed. And then Gebremedhin is going to talk about what's happening in Ethiopia, and then I'm going to show pictures from my recent trip to Cape Town. I actually have a talk after that too, but we'll see how far I get into the talk. Okay, so does this work? Turn it on. Okay. Great. Okay. So this is the web page for the Toronto Addis Ababa academic collaboration, which is a very impressive collaboration that started in 2007. There was a psychiatrist by the name of Krahn who's on the Toronto end, who was the first person who developed this initially collaboration around psychiatry, and has grown now into a very impressive collaboration that expands across dentistry, applied science, faculty of information, faculty of medicine, faculty of pharmacy. And the intent is to develop high-level, both clinical and non-clinical training for people who will stay in Africa and build HTA and other types of capacity there. In the past, there have been lots of training programs that have brought people to North America or Europe, etc. What happens is that there's often a very significant brain drain, and this is a very interesting and very successful collaboration to build capacity in Addis. There are a number of, as I said, groups that have been contributing. I went in 2017 to Addis to teach pharmacoeconomics, and since then BPharm has been going. We've had other people. Linda McKeegan started this, Petros went, Mary Ellen Hogan, who was a student here before, to teach a course in pharmacoeconomics. Gebremedhin has been teaching and probably will pick up this teaching responsibility on a permanent basis. Anyway, it's been a very successful and enjoyable collaboration. I think you're going just again in a few weeks, if the COVID-19 thing allows. That's my class, and I just looked back at these slides, and I was actually incredibly pleased to see that this person here, who's sitting in the front row, actually showed up in Cape Town, and he's been very successful and productive and had a lot of fun. And this person here also showed up in Cape Town. So it was, like, for me, it's been just a professionally very fulfilling relationship, and I'm in Cape Town was shocked to see the seeds that have borne fruit. This is one of them, so I'm going to actually let Gebremedhin talk about this and talk about his experience and what's been happening in Addis over the last, 5-10 years. Let me just put that onto your file. Okay.
While we get through.
It's like your 96 slide.
Thank you. So I'll be presenting very brief what we are trying to do in establishing the HTA in Ethiopia. So I'll have a brief introduction for those of you who do not know where Ethiopia is located, and we try to look into why HTA is important in Ethiopian case, and we try to see also what are the barriers that we are encountering throughout the process of establishment of HTA, and what has been done so far in terms of establishing the HTA. And finally, I'll try to touch a little bit about the future, what we are thinking to do in establishing the HTA. So for those of you who do not know Ethiopia, it's in East Africa, and we have also a lot of tourist sites which has been registered in UNESCO. This is one of the sites that you could find it in Afar, and so far we claim Ethiopia is the origin of humankind because we have the old fossils, as you might know. So with this in mind, we are also the second populous country in Africa with 105 million population next to Nigeria, and it's made to increase the population because, as you can see, the fertility is very high because of several factors. And with this in mind also, Ethiopia is one of the poorest countries actually. But the good news is for the last 15 to 20 years, we had a very good development. The annual growth of GDP has been 2 digits, where we can average about 10% growth for about 15 years. But still, the GDP per capita is even less than 1,000. But even with this income we have at country level, it was possible to achieve most of the Millennium Development Goals related to health. And even the under 5 mortality has been achieved 3 years before the target of MGD, maternal mortality 1 year before the targeted MGD. So it was really successful in terms of health. This has been because of the developments in the economy and also the support from the NGOs. But in addition to that, the education sector has been developing a lot. We had a lot of universities being built in the country. But still, Ethiopia has a high morbidity and mortality, and it's within the double burden where we have a large mortality because of infectious disease, but we have also an increasing prevalence of those non-communicable diseases, cancer is increasing dramatically in the country, DM is also increasing, other non-communicable diseases are increasing. And with that in mind, we have also a huge challenge in terms of increasing access to healthcare, even to the basic health services. And there is a large disparity of this access into the healthcare system, where the number of healthcare professionals especially are being concentrated in those urban cities. Medications are more in the urban cities, but the rural do not have access to most of the medications. So with this in mind, and in line with the WHO recommendations, Ethiopia has been working on ensuring universal health coverage through implementations of the health insurance. We started a decade ago. It's we have 2 schemes. The community-based health insurance system is for the informal sector where they are not employed and they don't have regular income. They're going to pay a minimal amount of money for contribution to the health insurance system. But we have also a social health insurance system, which is for the formal employees, working as a formal employment in different sectors, where they are going to contribute about 3% of their gross salaries, and 3% is going to be contributed by the government. So these all community-based health insurance system and social health insurance systems are compulsory for everyone. It's not based on our own interest, but it's compulsory for everyone. So we started for the community-based health insurance system, but not for the social health insurance system because of some challenge from the employees. So with this, we know I have been involved in selections of generic medicines for the National Health Insurance System, and it's really amazing to see there are different factors that could affect you in choosing the medications. Most of the process of selecting these priorities is based on literature that we have been trying to use, but there are also a lot of pharma industries lobbying to introduce, So the impact is huge unless you have clearly defined on how you're going to choose these kind of medications, any kind of technologies into the formulary. That would be a very difficult situation. So the health technology assessment came into the mind of the policymakers, and they tried to make sure on how to make the priorities. So the fact that there are a lot of options in the table, and the fact that we don't have evidences was one of the big challenges we have in selecting those generic medicines. So in any way, in the different guidelines coming out into the practice in the health insurance system guidelines, reimbursement guidelines, they were trying to aspire having health technology assessment principles being included in selections of these medications and any technologies. So there is, I can say there is a very strong demand of establishing health technology assessment. And from that point in, then the government is working on establishment of the health technology assessment. So the question is, when you see people from WHO or other, the Westerns, like whenever you try to talk about health technology assessment in the low and middle income countries, they look at you know, like fancy things. They believe it's not important for the low income countries. But I would say I see it the other way. Like the health technology assessment is more important for those who are less developed with resource limited options. So when we see if this is really important for Ethiopia, indeed it's very relevant because we have lack of resource. And even with that resource, we need to make sure that resources are utilized efficiently. The allocation has to be rational. It has to make sure that we are using it efficiently. But on the other hand, it's not only the limitation of the resource, but we have also a huge increase in demand because of several reasons. Like one, due to increase, for instance, life expectancy, due to increase the burdens of the non-communicable disease, and several other factors are increasing demand for healthcare. But here, the contribution of the government is very, very limited. It's only 30% where the government is contributing to the health sector. Like 33% is from out-of-pocket expenditures, about 36% is from donors, external donors like NGOs and government aids from different sectors. So the other thing is there is a substantial reduction of global donations. One example I took is the BPharm, where it decreased about 80% decrement in funding for HIV. That's going to be a good indication that we cannot rely on aid, and we have to make sure, even if it's an aid, like if we take examples of vaccine, they are all supported through Gavi. So we're not introducing them through basic economic evaluations, but we are introducing from the recommendations of from the Gavi or WHO because we're getting them for free. But the thing is, we're not sure what will happen if they are not giving this vaccination program without donation. So we need to make sure, because sustainability is going to be a big issue, we need to make sure anything we're selecting is value for money, and we need to make sure it's relevant for the community. That's something in question, and HTA could be really helpful as an evidence to look into that regard. So if there is a huge interest in the government, in the academia, in everyone, so what are the barriers for introduction and practicing of HTA in Africa or in Ethiopia? So one of the major limitations in Ethiopia, there is a survey done by one of our colleagues, one of the major factors he finds is it's because of the traditional decision-making process where people are making decisions based on their own experiences, and whenever you go to ask them to change their decisions through the evidence, they're not really happy to accept, you know, and even when you are asking to get budget for doing this kind of economic evaluation so that you can give them evidences, they are not really happy on that regard. So the reliance on traditional decision-making culture is one of the major barriers. And the other is the lack of skill, what's the purpose and importance of HTA or economic evaluations in particular. And the third major one is the limited awareness and the lack of skills. Both are one of the major barriers that has been identified by the survey. So from that period on time in Ethiopia, the government established in 2015 the Health Economics and Financing Analysis Team, which is equivalent to HTA here in Canada. And then the whole purpose is to do economic evaluations and other supporting evidences in order for the high-level policymakers to make decisions on priority setting. So before they do for a specific economic evaluation, their primary target was to revise the essential health service package, and this has been launched in November 2019. They have already developed the priorities for essential health service packages for Ethiopia. So the next step in this department is to do economic evaluations of each interventions for each priority area. That's what's happening in Ethiopia. But so far, even in development of this essential health service package, the current practice of this selection, priority setting, and even clinical practices, guideline preparation is mainly based on expert opinion and literature. Like even the budget impact, the priority setting, the ranking of all services was done based on Delphi approach, like taking consensus of different experts working in the similar area. So we are relying on expert opinions and literatures because of one reason, because we don't have data and we don't have economic evaluations and HTA evidence. The critics for this department in the ministry, there is lack of adequately trained multidisciplinary team. They are not adequately staffed, and the level of training that they have to do this and to understand this economic evaluation is not up to the requirement. And it's really fragmented. There are people working in the university, this economic evaluation, people who are also working in other departments, but there is no any collaboration between. Sometimes you can do the same topic. You know, we have a limited budget, but we are doing the same project using different source of research for a single research problem. So lack of communication. So we need to have harmonization. But one of the big questions is neutrality, because in the ministry, it is the ministry who is the buyer, the supplier, and regulators of the services. So that will have its own problems in selections of these priorities. So there are efforts in the university working with THETA and Addis University to establish a Center of Excellence for HTA at Addis University, and similar initiatives are also undergoing at national level. So challenge of conducting the HTA studies, once we have this kind of interest from the government, so why don't we do these HTA studies in the country? One of the big challenges is the inadequate technical capacity to produce economic evaluation evidences. So the government understands this, and they have launched health economics as in master's program, and we have also increased more HTA-related courses, like the course we are giving in the pharmacy through THETA and pharmacy department collaboration of UFT. There is also thinking of launching clinical epidemiology program that would be helpful for this purpose actually. And one of the big challenges again we have is lack of data input, and available are low quality research, and especially if you look into the effectiveness data, we don't have such strong clinical trials that can be used for economic evaluations. And we had no any utility studies before I met Mary actually. So once we did that, again, if you have even all these data, there is also lack of guidelines to how to do this economic evaluation in the context of Ethiopia. So what we did so far is, once I met Mary, as I mentioned in Addis University, then we tried to discuss what if we can have population level utilities, the tariffs for Ethiopia, and then we can extrapolate or map it into specific disease health utilities. So we tried to write a proposal to EuroQol, the European Quality of Life, and then they gave us a grant, and we tried to develop based on 1,050 populations in the country, considering different kinds of strata. And these tariffs have been used for development of different kinds of disease-specific utilities. We developed for breast cancer, we developed for cervical cancer, we also developed for HIV patients, and based on these utility values, we already started doing economic evaluations. For instance, for this one, where BPharm is involved, is DCG-based and FRCPC-based economic evaluations for treatments of HIV patients. And many disease-specific utilities are in the pipeline. We're trying to prepare those utility ones that can be used for doing economic evaluation. And these are some of the examples where other colleagues are being involved in doing the economic evaluation in the country. You can see many papers are like either they are published in 2018 or 2019, most of them. And you can imagine how the importance of economic evaluation in Ethiopia is evolving. And most of the economic evaluation done by other colleagues are based on DALIs, or some of them from Harvard University by considerations of equity and financial risk protection. These are most of the papers that you can find from Ethiopian context. But in any way, it can show that the economic evaluation and the HTAs are increasing in Ethiopia. So the future is, we know that there is strong demand from policymakers and the universities to establish and to work more on HTA and economic evaluation, and the number of expertise is increasing. Almost all of the papers that have been published are through collaborations from the US, the Europe, or Canada. So that has been has its own impact on increasing number of expertise in clinical, in economic evaluation. So the thing is, we have resource and infrastructure limitations still. The commitment, although there is an interest, the commitment is not up to what we expect. So the future has to be, we are working on establishing an independence that can support the ministry, an independent HTA in Access University. And with that, we can work more like development of guidelines, doing selected cost effectiveness analysis and the like. So that's what we are trying to do. Thank you very much. Yeah.
Our original thought when we started to do this utility work was that preference studies, particularly having a community-derived preference set for a particular country, would have a kind of a catalytic effect in increasing the interest and volume of not just utility studies, but health economic evaluation. And I think you can see that this idea was not completely off. I mean, I'm just actually quite surprised as to how many utility studies have come out of this. At this conference I went to in Cape Town, that I'll talk about in a minute, I think there were 4 separate presentations on utility values that have been presented using this preference set that Gebremedhin and Abraham developed together. So it's catalyzed, I think, a lot of utility preference studies as well as economic evaluation. So I think in part, because of this work, the EuroQol Foundation, which is headquartered in Rotterdam, started to get interested in Africa. They have preference sets for, I think, 130 different countries. They haven't done a lot in Africa to date. And I think, and I could be wrong, you can correct me if I'm wrong, but in part because of what Gebremedhin and his colleagues have done in Ethiopia, they became aware of the possibilities of working in Africa, and also, they also have an interest in spreading the use of their instrument, obviously. So they organized this first ever EuroQol African colloquium in Cape Town, which I went to in February. We talked about, it's very interesting, to go to 2 days of presentations on one instrument. It's basically 5 questions. So it's the E2/B in cervical cancer, E2/B in breast cancer, and it's like, 48 hours of just E2/B and that application. But still, it was, what was really cool was to meet people from all over Africa. And I mean, it was really inspiring to see how people from North Africa, from Central Africa, South Africa is a beautiful place, by the way, if you have a chance to go. This is like this Table Mountain kind of looms over the city.
Wow.
You can just, everywhere you go, you can sit on the beach and have a picnic if you like. This was, I gave a talk at this Groote Schuur Hospital, which was the hospital where Christian Bernard did the first ever heart transplant in the world. This is like in the 1970s. This is our hotel, lots of vineyards. You can't have picnics outside because of baboons. Lots of partying, as well as like hard academic work, of course. And these are some of the people these are both people from my class, Silam and Abraham. I don't think Leah was in my class, but they're both came to this meeting, and they're actually all interested, all 3 of these are interested in coming to do a PhD in Toronto. Went to Robben Island also, which was very cool. That's where Nelson Mandela was in prison for many years, and this is a political prisoner who knew Nelson Mandela personally, took us around. That's the view of Cape Town. You can see why it's called Table Mountain. It kind of looks like a table at the top there. So I'm, in the remaining few minutes of this talk, going to say, I'm going to give this talk, which I gave there, which is to talk about the challenges associated with implementation. It's cost utility analysis. That's what they were focusing on, which isn't quite the same thing as HTA, but a lot of the issues are the same. And I am going to be covering some of the same territory that Gebremedhin so eloquently covered already, so apologies for the repetition. So this is me, like this is a wildly overstated picture that indicating our global influence, but we do sort of have some connections in these places. What I was trying to say here is that we have some connections in these places, but I am not really an expert in African HTA. I've done a little bit here, worked in Uzbekistan a bit, in China a bit. So I have a superficial understanding of the issues, but I didn't really stand in the way of me giving a talk all the same. Some of the things that I was asked to talk about the things from very granular to very abstract. And so starting from the very granular, many times just the basic infrastructure for doing economic evaluations was missing. Like a lot of the students didn't have internet access, for example, at home, so they had to sort of stay at the university and do their work there. Computers, power space, practical things like that were not available. Even modeling software, we teach people to model in Triage, but Triage is expensive. It's like, $1,200 Canadian for a standard license, which, in an African context is just absolutely just not feasible. So you have to find alternative approaches to modeling. You can build models in R or in Excel, but, just practical things like the cost of software is a real barrier. Another thing I learned when I was there is that journal access is actually a fairly big issue. Many African universities cannot afford subscriptions to these very expensive journals, and as a result, people use things like this. Does anyone know SciHub? Yeah. So this is kind of like a pirate site. I asked the same question when I was in Cape Town. Almost everybody in the audience put their hand up. I mean, this is sort of illegal access to the world's scientific literature, but this is what people use to get around these sort of barriers to access. And they were using the same thing in Uzbekistan when I went. This is like a great boon to lower and middle income countries. Then Gebremedhin talked about this a little bit, and I think it's true that expertise is lacking, but as most of you who work in this area will know, the distribution of expertise that you need in this area is actually fairly wide. It's not enough to know some economics. It's not enough to know some modeling. You also have to know some biostatistics. You also need to know some epidemiology so that you can read the scientific literature and interpret it and translate what's in the epidemiologic literature into models. And there are other things that you need as well in certain circumstances. So you need to understand about resource allocation ethics, measurement, health services, research, etc. So the range of expertise that you need to do this kind of work is actually fairly broad. There are actually some programs in Africa. One of the things I learned when I was there is that the University of Cape Town actually has a long tradition of training people in health economics in particular. And they have a master's and a PhD program there. And this is a few years old now, but you can see where their students come from at the Health Economics Unit at Cape Town. A lot of them come from South Africa, Uganda, but they basically come from all over Africa. Not so many from the northern countries, but mostly from Central and Sub-Saharan Africa. A surprising number of them actually trained in York, went out of the country. So if you're going to do economic evaluation, you need some place to do it. And that, you can't just sit at home and do your economic evaluation. So that usually means working in an HTA agency for government or in a university. And then I explained what our HTA agencies were like in Canada. And there is an HTA interest group for developing countries, But the number of HTA agencies in Africa, as you can see, is pretty small. I mean, South Africa is developing an HTA agency. There's some early interest in Ethiopia. Ghana actually has surprisingly sophisticated group of people that are working in HTA. But in terms of formal members of ENATA, as far as I know, there's actually only one at the moment. That's in South Africa. What about the data needs? Gebremedhin touched on this briefly, and I'm just going to slow down and go through this in a little bit more detail. I mean, to build an economic model, you need data. You need data about what people's life expectancies are. You need to know how people are cared for. You need to know the natural history of disease in local context. You need to understand how well treatments work in the local context. And many of those things are not available. Ideally, you have a national community-weighted preference set, which now we have in Ethiopia, but you need other things too. You need, in specific circumstances, condition-specific preference measures, and mostly you need expertise so that you can take things from the literature and combine them in intelligent ways. And that degree of expertise is not very widely distributed. Costs are a problem. We spent a lot of time over the last 15 years here developing methods for improving the quality of our costing. But in an African context, that's often quite difficult to do. There's no such thing as large-scale linked administrative data that allow you to follow people over time. You can often get costs at an individual level or at a hospital level, but this resource use over time is very difficult to come by. And I talked a little bit about how we do this in Ontario. In terms of knowledge translation, there's different models of knowledge translation. There's the push model in the US where you sort of do your economic evaluation and you push it out to the world and you hope that someone will take it on board, but you don't actually know where it will go. And then there's sort of a pull model for single-payer health systems, and as Gebremedhin was suggesting, there is interest in this information. There is demand for this information, so I think the pull model probably works more for lower and middle income countries. Guidelines, I think, are important because guidelines about economic evaluation is not, strictly speaking, a technical activity. It is a combination of an activity that involves science and values, and to the extent that values are not universal, you need guidelines that reflect sort of local values. And these have to do with things like intergenerational equity, the role of individual versus community preferences, discount rates, that sort of thing. So, effective use of cost-effectiveness analysis involves, I think, country-specific or jurisdiction-specific guidelines. And then once you get beyond simply cost-effectiveness analysis, you need to think about how cost-effectiveness considerations are brought into broader decision-making. That means how should we consider factors such as evidence and equity and patients' preferences and values, implementation considerations, how should those things be brought into decision-making? And that requires the development of some sort of formal decision framework that places a role on economic evaluation relative to other things. And I talked a little bit about the decision framework that we use in Ontario, and we'll go through that in detail, and how that related to the decision framework that is sort of implicitly in this HTA core model, which is put out by the EUNETA, the European Union Network on HTA, and talks about many of the same domains that we have within our own decision framework. And I think, and the last thing that's important, that's taken, and this is sort of an intangible thing, it's kind of a culture of evidence-informed decision-making. And Gebremedhin was getting a look at this in a way, in the sense that he described one of the challenges to implementing a formal HTA approach is sort of the way in which people make decisions. Like, HTA always arrives in some country in the context of some other decision-making framework. And, decisions tend to be driven by people who are locally influential, people who are thought to be authority figures, and that sort of thing. And it takes time to develop a culture of evidence-informed decision-making so that people who have the capacity to make decisions about publicly funded technologies can actually speak the language of evidence and rely on evidence. And that's in my experience, which is now about 30 years long in Ontario. It's taken all of that time to change from essentially the old way of making decisions to a decision at least that is nominally informed by evidence. And I think it just takes time to train people and to use this language and create sort of cultural change within ministries of health and places like that can use new evidence. And that is all I have to say, and I'd be happy to take questions or comments. Gebremedhin, do you want to come up and field questions as well? This is all like totally transparent, extremely clear. Yes.
Thanks, Mr. Very impressive presentation. I was just a bit interested whether there's been any efforts to reach out to other African countries in the region who probably may be doing similar work or maybe to connect. I'm not aware if there's any country that tries to do this in Africa, for example. Or you know more about that than I do.
I think like because we are starting from the different perspective, we don't have the kind of collaborations with other African countries. But as far as I know, there is also, I think, there are societies who are working in African states. They have, like, for instance, for the next October or November that I attended that. There is a conference in Addis in Ethiopia, which is about priority and cost effectiveness in Africa. So there are initiatives in Africa. There are also other societies who are working in this regard, but we're not as much involved because we are at the, at the initial infancy stage. But I hope like those developments which are going under different countries might be a good opportunity.
At this meeting in Cape Town, we had people from Egypt, from Tunisia, from Ghana, from Malawi, Zambia, South Africa. I'm sure there are more, but I was surprised actually how many countries in Africa they don't all have HTA agencies, but they all have people that are starting to work in these areas.
I just want to add, I think it's just really important, or this highlights how important it is to have this type of meetings and conferences in Africa. So the one you sent me earlier today, it's amazing. And the International Health Economics Association is in South Africa in 2021. So I think to have this opportunity so people can actually connect, where it's incredibly important to build those relationships, because usually it's, as you know, in a Western country, so people from Africa are unlikely to travel there, don't get scholarships and everything else. So it's just hard to connect overall. And there's also the African, the Health Economists Association. I can't remember the exact name. So they also meet every 2 years, I think. Yeah.
So it's very interesting because I think the reason I ask is I know, like, for example, Kenya itself is also going through the same process where they're trying to establish a universal healthcare system, and I'm thinking whether there's been similar effort towards thinking about HTAs and similar things. And, with a lot of health economic people, that some of them that I know, but I don't know whether there's been any thought process towards going through the same what you guys are thinking. Because I presume the challenges will be the same. Obviously.
So there's a group called IDSI in London, and they're very interested in exactly this issue. So using HTA to stimulate the development of universal health coverage. So they've been very active, like countries around the world, particularly in Asia, are very interested in this question, and a lot of countries are trying to develop packages. And the other talk I gave there was around this issue on how to use HTA to develop universal health coverage. So it is an issue for many African countries, but other countries around the world. It's not that straightforward, though, because to develop, I mean, if you just think about the multiplicity of interventions that you could have, I mean, there are tens of thousands of interventions. There are tens of thousands of conditions for which interventions can be applied, and just multiplying those things together. Usually, an economic evaluation is a treatment for a particular condition. It's quite a large task to do an economic evaluation of everything potentially in the health system, and then so it has to be done in a sort of a phased, incremental kind of way, and usually the universal health package is not itself defined on the basis of HTA, but on the basis of other considerations.
So I'm also not sure if like INARA, like are they involved? Like I know on the vaccine side, they have WHO supports the MATEX and they need and kind of have specific criteria of what qualifies as a national immunization technical advisory group, I think. So what qualifies as a MATEX, and then there's like a map and kind of and they provide support of how to set it up. But I don't think there's something like that on the HTA side more broadly, or not that I'm aware of, but INARA or someone I don't know. No.
Just asking someone sort of outside the field here, but having worked in Ethiopia, what is the role, positive or negative, of the private sector in this type of work? What's your experience in terms of how they participate in that?
I think one of the challenges we have in Ethiopia, for instance, once the government starts the health insurance, there is a huge gap in terms of pricing the healthcare services. And even in doing the economic evaluation, one of the challenges we have is how to calculate the cost. Like the price that you find in hospitals, it could be like based on $1, but if you go to the private sector, it's like way above this amount of payments from the public. So in doing that, the government is trying to make negotiations in order to have similar price. And this is being done through the health insurance agencies of the Ministry of Health. So the thing is, when they reach into this consensus, probably the private sectors are going to be on board. And we are also having courses in the private universities, and that would also be helpful. And I think that would be relevant in terms of contributing to the health technology assessment. But so far, there is no, as such, a very well-organized kind of collaboration between the private and the public. Most of them are on the public aspect.
Really interesting presentation. I wonder if you could speak to actually to this last slide here and about the general process of adoption of a formulary system within Ethiopia, both at a national level and also then at the institutional level, and whether or not there was a movement towards, as the formulary grows, that the base foundation was, say for example, essential pharmacotherapy list as the foundation independent of economic evaluation, that we think we should have access to this medication, and then how the incremental then would build to that.
So we have institutional, we have also national formularies, but whenever we're trying to make these selections, we try to categorize them into vital, essential, and less essential. And in doing that, the expectation, and even in the criteria, is like we need to include criteria, like there are about 7 criteria we use in the selection process, where one is the evidence of economic evaluation, but we don't usually use it because of lack of data.
Okay.
But this time, people are trying to use, other countries from the literature, which may not reflect to our context because the pricing, everything is, I think, different in terms of that. So we're trying to do based on the experience. And if you see the basic health service package preparation, in one of the criteria that they have been using in those selection process, they have been using a Delphi approach in most of the case from expert opinions, consensus. So we don't have as such very strong evidence in the selection process, but there is an interest in that.
Thanks for the talk, really interesting. I know in Europe, countries or the EU, I don't know who decides it, they negotiate together for drug prices, for example, to keep the costs down. Has there been any initiative now that Ethiopia is trying to create universal healthcare, other countries, possibly Kenya, has there been any initiative in Africa to try and do sort of cross-national negotiation of services and, private sector, public sector sort of drug prices and things like that? Because it sounds like you said, there's a lot of lobbying. I can imagine that if it becomes well known that Ethiopia is creating a public healthcare system, there's a lot of international actors who might want to, get some profit out of that.
I think the system we have is a little bit different from other countries. We have a national procurement agency And the main reason why we established the National Procurement Agency is to have advantage on negotiation. So you can imagine for more than 105 million population, the amount of drugs that we can buy through one supplier will have a huge advantage in negotiation. And we see like medications procured by the private sector and medications procured by this agency the difference in price is very huge. Like it might be sometimes you can find it for $1 in the public institution, but it might be like $10 in the private. That much difference can be observed. So I see like it's because of the negotiations for the public sector that we are getting less price, usually actually for generic drugs.
But to just follow up on that, like, are there any intra or between country collaborations to? I mean, Africa is a big place.
Yeah, I think in East Africa there is an initiative to do such kind of procurement. That kind of initiatives through EGAT, but there is no such kind of procurement so far.
You would imagine if you can add multiple of the national agencies together, you might, get it down to $50.
Exactly.
Yeah.
Is most of this work being championed by universities and academic agencies, or has there been meaningful buy-in from government and insurance providers?
You mean the economic evaluation?
Yeah, and the HTA movement.
Yeah, so the HTA is from both sides. Like the government, as I mentioned, in 2015, they have established the HTA, like Health Economics and Financing Analysis, because they want to make sure any decision is based on evidence of economic evaluation. So they stopped doing the economic evaluation because they want to focus on first prioritization. There are a lot of support from the US and Europe where now they have already finalized in November 2019. So the next activity as a plan from the ministry is to do economic evaluation for the high priority intervention, high priority settings. I mean, kind of diseases that we want to address. So the academic is also working in a different setup, but that's what I mentioned. There is no as such a very strong collaboration between the academic and the ministry. And that's what we were trying to do to negotiate in order to have HTA at the university so that we can have support from the ministry. Whenever they have priority areas for economic evaluation, the institution can do it independently and that they can use it for decision. Rather than doing the economic evaluation by the ministry and then making decision by themselves and then procuring by themselves, regulating by themselves, that will have a problem. Making one institution as purchaser, supplier, and regulator. We need to have an independent, but they are supporting us to establish actually, and we hope things will be good. Yeah.
So just to end, so when you're trying to build capacity within a country, that's always the question. Should you start with the political apparatus, people who have the money and the power, or should you start at the university and build capacity for people who learn and want to actually do it? And I mean, I've heard different things from different places. Like last year, I heard a presentation from the Ghanaian group, and they said, in our country, the thing that works is to go to the top. And they had the Minister of Health actually had come to this meeting, this HTAI meeting. I think it was in Cologne, and she talked about how important this was, and they just made things happen in the Ministry of Health in Ghana, and then everything happened at the university level after that. So our experience in Ethiopia is really, or at least our personal experience is more at the university level. It's sort of like building capacity, and I think the answer is both, but where you can work kind of depends on the context.
We have one online from Sandra.
From Sandra?
Yes.
From Uzbekistan?
Yeah. He said, great presentation, both of you. And the question is for Murray. What differences and similarities in a culture of evidence-informed decision-making between Uzbekistan and Ethiopia?
Oh my goodness. I better speak into a mic so he can hear me.
The standing one is on if you just want to.
Oh, okay. So thank you for listening, by the way, Sanjar. It's great to have you here. The thing is, I don't think I know either Ethiopia or Uzbekistan well enough to be able to answer that question. I mean, my sense is that it's early days in terms of a culture of evidence-informed decision-making for both jurisdictions, but to be honest, I mean, I've been to Ethiopia once, I've been to Uzbekistan once, both for short periods. I am by no means knowledgeable deeply about either of those places. So my sense is that it's at an early stage, but I don't really know.
Just a follow-up question on, and I think this has probably been mentioned in passing, was, so it's, I'm quite impressed that the government is actually taking this on board, trying to actually take the initiative about the HTA. So how much are they actually then investing in the capacity in terms of, I'm assuming, getting capacity to be able to do this HTA, either at the ministry level or at the university level? And you've mentioned or alluded to the fact that you're starting to master's course at the university, and I don't know whether that's being pushed by the government. Are they offering any support? So how much is the government involved in trying to actually realize the capacity to be able to do all this?
I think, to be honest, for instance, when we are starting health economics, not in the pharmacy, we have health economics in 4 universities in Ethiopia. So even the initiative came from the government to launch the health economics because they have seen these gaps through communication in the international arena. So they are also supporting hugely for the health economics to be functional, and they have a lot of graduates now, and they are recruiting more, but not adequate so far. But I can also see support like in the ministry when they are working on the priorities. So they're trying to support and trying to help us having networking with the different universities from Europe. Like as Mary also mentioned with IDSA, they are working a lot with IDSA. And whenever we go to ask them for collab anything that we want to do, actually they are very receptive. They want to help us in that regard. The thing is, we need to work the baseline. We are trying to work on the resource mapping, on how to proceed. All these things have to be done before we bring them on board, but they are really supportive in terms of that. The only problem might be financial support because of the lack of resources we have.
Hi, great discussion. Just wondering about the end users. You already mentioned it, the challenges of traditional decision-making, lack of awareness, and there was a third that I forgot. So do you, in parallel, make a plan on how to involve the end users to actually implement what you're doing? How is there a whole project? And like here, it's already challenging to make our traditional doctors change the way of taking their decisions. I can understand that in Africa it may be even more challenging with also traditional medicine that is there as well. How do you try to tackle that?
Yeah, even from the inception, when we are trying to establish the HTA, like the first thing we did was we go to the ministry, and there is also a separate agency for health insurance agency, which is going to be controlling or doing all the health insurance in the country, which is mandatory for everyone. So they are the ones who are going to select the medicines to be prescribed for the patients. So upon those preparations of formularies, we were agreeing with them that they are going to use the evidence generated because of this center. So I think they are on board and they want to have those evidence for decision, and they are eagerly waiting to get evidence actually.
I see they're open to it.
Yeah, they are open to it. They want to use it. The problem is they can't get, like I mentioned, for the preparations of priority, those health service package, they were searching for any evidence in order to use it for selection and prioritization, but they can find local evidence. So I'm sure like they're very receptive and they want to have it. Yeah.
Maybe even more than here.
Yeah. Any questions?
Okay. Thank you.